our next dynamic duo, Madison Fox and Julia Martin. So Madison is a speech pathologist and clinical specialist for the inpatient team at Stanford Healthcare. She specializes in the evaluation and treatment of communication and swallowing disorders for patients with neurogenic, neurosurgical, and critically ill patient populations. She's participated in the development, and I'm going to try to get it to stop doing that. Swallowing and aspiration pneumonia rate reduction. She served on the board of the California Speech Language Hearing Association from 2022 to 2024, and was also a lecturer at Cal State East Bay in the Department of Communication Science and Disorders. And Julia is an inpatient speech language pathologist also at Stanford Healthcare, where she specializes in evaluation and treatment of adult neurogenic communication and swallowing disorders. She provides person-centered care for patients on the neurology, neurosurgery, and neuro-ICU units, and co-leads a community communication group and is committed to mentorship through supervision of students and clinical fellows. Thank you both for being here.
Thank you, Heather. Yes. Hello. Thank you again for having us. This has been wonderful so far. We feel really privileged to be talking to you tonight. We're going to be talking about the how of some of the things we've been hinting at, which is centering our patients in decision making. And we'll be talking about some of the skills that you can incorporate as clinicians to enhance the conversations that you have with your patients and really bring their goals and their wants and their preferences to the heart of what you do for them. We those are our disclosures, and it's like very sensitive. I think it's I don't know if it's skipping on its own, but we'll see. Yeah, those are our objectives. That's essentially what I just said we're going to be talking about.
Okay, so I think we can all agree in this room that we know this successful patient-provider partnership is built around these foundational concepts of patient rights, where a patient is legally and ethically allowed to make decisions about anything that happens to their body. This idea of informed consent, where a patient has to voluntarily agree to any test or treatment that we are proposing for them. Thank you. And then this concept of shared decision-making, where the patient is at the table with us when we're coming up with care plans. But what we've really found, and what kind of spawned this presentation for us and what we're very passionate about, is that the way that we have these conversations can be the missing piece. And this can be what really brings it all together or breaks it all down. And we can see this reflected in some of the things that we have had patients say to us and might sound very familiar to you as well. So something like, if I don't get some water right now, I'm going to leave the hospital. More tests, more tests. All you people want to do is more tests. I've been swallowing my whole life. I don't have a problem. So it can be hard to respond to something like this in the moment when it catches us off guard. And this is really where this talk came from. So despite the fact that we know we want to center our patients, it's clear that our patients aren't always feeling understood by us. So we wanted to figure out where this breakdown is happening and how we can try to repair. Okay. So we want to emphasize too that when we hear these statements and we're understanding that our patients are not being heard by us, there's this growing sense of powerlessness. Maybe a feeling that we are not respecting our patients' wishes. Maybe they're feeling like a child. They're not feeling dignity and autonomy that we want to be giving to them. A lot of this also comes between this tension between our desire and ethical responsibility to do no harm, and this idea of patient autonomy, when those two things might feel at odds.
And there's no clearer example of this tension, especially in acute care, than when we think of and reflect on this word risk. So this word comes up a lot in care. I was reflecting a little bit about what, Teresa, what you were getting at, which is you want to ask your patients what their goal is when you first start. And in my head, my mind went immediately to, but what about the doctor's goals?
What about the family's goals?
Family's goals? What about the hospital goal to reduce aspiration pneumonia rates at the hospital? Because we don't want people getting, infections when they're in the hospital. There's competing goals. And so we're very concerned about this idea of eating with risk in the hospital. So Julia, what comes to mind for you as a clinician when you hear the word risk?
I think it's something to avoid, something that we might fear or people might fear, something that might paint a patient as non-compliant or difficult if they are wanting to take this route.
And so I think for me, what I like about reflecting on that answer is that it helps us understand that when this word is getting thrown around a lot and when we're putting all of our attention on it, we're robbing our patients of the freedom to make a choice. Because how can you make a choice if everyone around you is saying, well, that choice is the wrong choice? You actually don't have freedom, true freedom to make that choice because it's being painted so negatively around you. So we also can see the absurdity of it when we think about the fact that everything we do in life has risk inherently tied to it. And our colleagues in rehab, physical therapists, don't have their patients signing waivers to get to the edge of the bed or to mobilize for the first time. Like, do you agree to walk with risk? Because you might fall. We're not putting so much weight on it. We're focusing on their rehabilitation over this fear-based approach. So it isn't that we're not saying, or it isn't that we're saying you shouldn't talk about risk. You absolutely have to talk about risk with your patients. It just can't be the only thing you talk about. So the process of informed consent means that we have to not just talk about the risks of doing something, but also the benefits of what we are proposing that they do, the alternatives, what are your other choices, what can someone in your situation do, and then also the option to do nothing and maintain the status quo. So if we omit any of these elements, we're gatekeeping patients from really making an informed decision.
And the kicker here is that even if we lay out all these risks and benefits, it's not going to get us very far if we don't take into consideration our individual patient, as is the theme of tonight. So we make a lot of assumptions about who we might think a patient is and what we might perceive their risk tolerance to be based on their patient profile, maybe where they are in their disease process. But our biases come into play. So we really have to get to know our patients and invite them to the table so we can understand how they perceive those risks and benefits.
I apologize. It's automatically.
I'm sorry. We're trying to flow with it. And so in order to achieve that, we invite them to the discussion. So there's been this shift, fortunately, in recent years away from this more paternalistic model of healthcare where I'm the provider, you're the patient, here are my recommendations, where they are maybe a passive recipient of these things, to this more iterative process of shared decision making. So I might be the expert in swallowing in the room, you're the expert in yourself. We can share this conversation together, get to know each other, and come up with a plan on the same team. And so we're starting to see a lot of the benefits of engaging in this type of practice in the literature. There's lots of robust evidence now showing that involving patients, unsurprisingly, in their care has a positive impact on not just clinical outcomes, but actually cost and also patient satisfaction, which we would expect. But there's a lot of careful wording in the literature that we also want to underscore that it's not because of these benefits that shared decision-making should occur. It's because it's this fundamental patient right that we do it. So we're now going to dig into a little bit of what it looks like.
So in order to go through the process of inviting your patient to the table, we can break it down into occurring into sort of three parts. At first, you have the realization that there's been a change in function. This is usually in your diagnostic workup. The status quo isn't working anymore, and it's time to make a decision about how to proceed and move forward. After that, you're going to lay out options, and this is where sometimes patients aren't necessarily ready to go into the option talk right away. The timing of how this pans out is really going to depend on how your clinic functions, where the patient is in their diagnostic process, and also at least in inpatient care, like what's going on that day, what else has been happening. We'll talk a little bit more about that. And so once you have gone through this process of exploring their values, getting to know your patient, going through options and seeing where they sort of feel like they might want to go, you come to a point where you're making a decision, and that seems pretty straightforward, right? Like, this seems like we should all be able to do this. But what's not included in this graph is the fact that we're working with humans who are going through an emotional process, all the emotions that come up, the complexities that arise when people are faced with making really critical decisions about their bodies and their lives. So there's this assumption implied that our patients already have a sense of what they would want to do in this situation, but we overlook the fact that this might be the first time someone is considering something like swallowing. And it's not something that people are always thinking about. We take it for granted in a lot of ways. So having the skill to help them explore this during that time of complex processing is a skill that we're responsible for bringing to the table. There's various approaches for how you can go through this. If we think about needing to gain insight into how our patients feel about something, getting to know their values and their preferences, there's some skills that we can, or some techniques that we can try. So one is the balance technique, and this is essentially being able to, with your patient, weigh your pros and cons. So here's the treatment that we are proposing. These would be the benefits or the pros of this, and then these might be some of the cons. And then with that, you also might want to help get a sense of not just whether or not something is a pro or a con for your patient, but like how much of a pro or how much of a con, how much is this going to impact you? Some of the quality of life measures that have been spoken about, I think, are good ways to think about rating scales to get a sense of how strongly something's impacting someone. If their scores are really, really swayed in the social area, then we know that that's where we need to put our attention, because that's having a big impact on them. But you know, it can also just be using a Likert scale and saying, you know, if I were to ask you to, at least temporarily for the next 2 weeks, give me 2 weeks to kind of let your larynx heal from this prolonged intubation, how strongly do you feel about this idea that you don't want to be drinking thickened liquids? Is this a 10 for you? Or are you just telling me you don't like it and you want me to know and recognize that and acknowledge it, but it's like a 3 or a 4 and you're willing to kind of go along with it?
Another one that we often find ourselves reaching for is this idea of social matching, where you're providing someone who, like Madison mentioned, may not have ever considered this before. They don't know what other people might do in this scenario, what's acceptable, what the choices are. Is just giving them that validation of, you know, some of my patients in this situation might choose to do X. Other people might choose to do this. Like, where do you fall in that category? And it gives them a little bit of camaraderie, that they're not making a decision in isolation. They're not making a decision that's completely different from what other people might choose.
So another tool that can be used is, they're called patient decision aids. These are used a lot with patients who have dementia when introducing the concept of feeding tubes and helping families navigate that decision-making process, oftentimes helping families understand the fact that the feeding tube isn't going to help the patient, which can be hard for families to accept. But essentially what you're doing is providing patients with written documentation in simple language, walking them through the types of questions someone might ask, because our patients and their families might not know what to ask you. And so if we provide them with documents of common questions that we get asked, it helps them digest the information. Maybe they can take it home, they can mull it over. And also we're presenting them with evidence-based answers that sort of depersonalize it. It removes me a little bit from the conversation. I'm not trying to persuade you to do something, but let's just take a look at where the evidence stands on this topic. And then you and I, as colleagues, or as not colleagues, as collaborators, we can reflect on it together and see how you feel. So this, will a feeding tube prevent my loved one from aspirating? That's a question someone might ask. And then the very simple, evidence-based sort of neutral response, no, feeding tubes don't. But as you can imagine, a patient-centered conversation, which is incorporating things like their values, all the different options, being transparent about the evidence, or sometimes the lack or sparse evidence that we have supporting what we might be proposing. It's not going to look too straightforward. It might look a little bit more messy. And so we have to do a good job navigating this. We have to do it with skill.
And this leads us back to this notion of effective communication. So we've established that we have this legal and ethical right to engage patients in this shared decision-making process, and we have all this evidence to say that it works. So are we doing it as providers? If we look at the statistic, we might say that only half of us are not doing shared decision-making, but I think we might look a little deeper and say that we maybe are engaging or intending to engage in these practices, but maybe close to half of our patients are not feeling that they are involved as much as they want to be. So we might not be doing it as well as we could. And this isn't because it's not just about what we say. Oftentimes it's how we say it. So if we get caught up in the content of what we're delivering, or following a blanket approach to how we communicate something to all of our patients without really considering their individual needs, it might not surprise us too much to find that our patients aren't feeling heard. And that's not to say that we don't all face very real barriers to engaging in this ideal type of communication in our everyday practices. So when asked about what these barriers are, providers will cite things like time constraints, which I know we all feel regardless of what setting we're in. Maybe the hospital environment isn't very conducive to having nice conversations in a very private space. caseload, the patient's cognitive status, emotional distress. And so all of these things are very real, and most of them we cannot control. But the one that we wanted to isolate and really talk about that we do have control over is our skill and our comfort level with these conversations.
Comfort level, I think, is key because
Yes.
it's uncomfortable at first when you're first learning how to have these conversations.
Yes.
So before we can talk about what effective communication, this missing puzzle piece, what it is, we can also take a moment to reflect on what it's not. So communicating my recommendations to my patient, proposing a treatment plan to my patient is not transactional. It's not persuasion. It's not me doing something because I'm trying to cover my tush and do the thing I'm legally or ethically obligated to do. It's because I'm truly trying to invite someone into a conversation about how should we proceed forward. There's not going to be a one size fits all approach. And we don't judge whether or not the conversation went well based on whether or not the patient agreed to what I proposed. I think that was a really important takeaway for me. My skill set in this is not whether or not they agree, it's whether or not they felt heard and that we came to a decision together that they were happy with.
And when it comes to delivering this news about swallowing, we have to really keep in mind at the forefront that this is really heavy news, and we have to just remember the potential gravity of these conversations. There's often a feeling that you're either good or bad at having these really heavy conversations. And I know for me personally, especially at the beginning of my career, I was so focused on my clinical skills that I tended to shy away from doing these things because I didn't feel comfortable or confident. And so we want to switch that narrative and really look at this as a skill like we would any other part of our clinical practice. And if we can see it like that, we can identify the fact that with practice and cultivation, we can become competent in this just like we are in our other pieces of our practice. And we can see that providers across the board need help with this kind of thing because there are so many different models and acronyms out there to walk us through delivering bad news, delivering difficult news. These can be really helpful, especially at the beginning, because they all have, as we'll jump into a little bit in just a couple of slides, similar elements, right? There's similar elements to these conversations that can make them go well. But we noticed when we were exploring a little bit is that if it's rigid and if you're just trying to follow a certain roadmap, that it doesn't leave a lot of room for flexibility when these conversations almost always take an unexpected turn.
So Teresa mentioned the serious illness conversation training, which is one tool you can start with to begin to explore some of these skills. We looked at other models as well as we were first going through those training programs, and it's a lot to make sense of. There's a lot of different frameworks. We found ourselves kind of asking, well, how do I keep all this straight when I'm in the room? And why does E in one mean explore and then E in another one means something completely different? It's a lot to keep straight. So what we wanted to do was boil it down into the commonalities between all these different frameworks, say, what do they have all in common that we can harness and say, these are the things I should be focusing on in my conversations with my patients. So we found that all the frameworks have a few crucial components. There's an element first of needing to prepare for the conversation and then explore. Oh, I'm at my steps. Sorry. Needing to explore and consider your patient's values. And then also we need to be able to, it skipped forward again. We need to be able to deliver the news in a mindful way, meaning that we're taking into consideration what we learned about our patients through the preparation and the exploration. Then you're going to be required at some point to respond to their reaction. Usually it's an emotional reaction. We have to work towards establishing partnership with our patients and then getting on the same page about what we're going to do next.
So preparation, we all do this when we meet with our patients, especially for the first time. This is what we're doing before we get into the room. Just like any other patient interaction, it's going to be more successful if we are able to do some legwork before we get in there. So this might be giving consideration to how ready is my patient for this news. In acute care, we're thinking about, like Madison mentioned, is it a good day? Is it a bad day? Have they just had a really significant procedure? Is it a good time of day? What's the medication situation? So trying to optimize the timing of that conversation can go a long way. This might be optimizing communication supports. Is my patient going to be able to participate in this conversation? Do they need a pocket talker? Do they need an interpreter? This is something that we've done, is like role playing and going through some examples of what we might be able to say. So grabbing a colleague and doing a role play can be really helpful for that preparation. The process of exploration, this is when you are interacting with your patient. This is identifying what matters most. So in thinking about the impact of dysphagia and so much of what we've heard from these great presentations tonight, these are the pieces of the conversation that help you get that out, help you get that information going as part of the conversation. So saying things like, tell me so far what you know about your swallowing problem. I have your FEES results. Are you ready to hear that information right now? How detailed do you want me to be? Asking permission can go a long way in starting these conversations. And to help people clarify their wishes, some people need us to ask really pointed, specific questions to help them clarify their preferences. So this might be something like, as you think about this situation, what stands to you as something we should focus on? Would something like a temporary feeding tube be acceptable to you? There isn't a right or wrong choice. What matters to you is what's important to me.
So when it comes to delivering information to your patients, we use the word mindful again to remind us that we're taking into consideration who our patients are as individuals, what's the vibe in the room, what's the environment, what kind of day have they been having, what are their values, cultural factors. We're trying to incorporate that into how we approach the conversation. And then the other piece with mindful delivery is this notion of preparing your patient for news. So in some papers, they refer to it as like a warning shot. You might say something like, I'm afraid, like the famous line in a movie, I'm afraid we have bad news, right? And then it gives the patient a moment to say, okay, bad news is coming. I'm going to put on my brave face. I'm going to brace myself and I'm going to be ready for this news. Or the test didn't go as well as we had hoped. I think I also try to incorporate this into my clinical bedside. If I'm suspecting someone has severe or profound impairment at the bedside already, I really don't want to wait until after the instrumental to be surprising them with, you know, we're going to do this instrumental. We'll see if we get you that cheeseburger, which is what the nurses say as we're wheeling them out to radiology. And I'm going back to the nurse like, no, don't say that. Because I'm trying to temper their expectations a little bit so that we don't have to have a big letdown, right? So I might say something at the bedside going, I know you're really excited to eat, but I'm concerned that you might be having problems based on what I'm seeing now. We're going to check to see what the swallow study says, but I'm already seeing some signs that there might be some difficulty. And I'm planting those seeds early on in the conversation so that we can be on the same page and maintain that sense of trust and partnership throughout the diagnostic process. So with the delivery of unfavorable news often comes the response. And this tends to be where we judge whether or not the exchange was successful. The patient gets upset, the patient starts crying, the family member's angry, or the last therapist, you know, blah, blah, blah. It's like, this is where we go, oh, I guess the conversation went poorly. And that's not actually true, because the feelings that our patients are responding to us with are normal responses to upsetting news. And it's part of a healthy process of grieving. And so we want to be respectful of that process. You don't want to walk out of the room and say to yourself that it went badly or they're being difficult, when in reality, it might just be also a mismatch between my skill as the provider in navigating and setting them up successfully for that conversation and their response, right? So we want to take ownership of this reaction and say that we play a role in how it pans out. It's not, it might be a normal response, but it also might be a reaction to the skill with which we navigated it. So let's look at some of the ways to respond to big emotions. These are some response actions or verbs that we can use in emotionally charged conversations. So one thing you might start off with is just labeling it, calling it out. Okay, I can see that you're feeling really frustrated right now.
Empathy, something as simple as, I know this isn't the outcome that you wanted. This isn't what I wanted for you either.
Legitimizing your patient. Anyone in your situation would feel this way. It's normal to feel upset that you're still stuck with this feeding tube.
De-escalating if the mood is getting a little bit hot, something like, ultimately you get to make the decision. I want you to be back in the driver's seat. We're a partnership.
And you can also apologize for things, even when they're things that are outside of your control. I'm sorry it's taking so long for us to see progress. Or I'm sorry that that thing that happened with the nurse this morning didn't go the way that you expected. It's not something I take ownership of myself, but I can apologize for it and show that I'm having empathy for my patient.
And we can show respect, giving them back their autonomy by saying something like, you know your body better than anyone else. You know your dad better than anyone else.
So we have some verbs of things we can say in these conversations. The order, when to say them, there's no recipe for that. So what's the secret sauce? The secret sauce is listening. Responding starts with listening, and our patients are telling us so much in the subtext of what they say to us that's where you want to target your responses if you're trying to establish partnership or de-escalate or respond to emotions. So when my patient says something like, "This feels like baby food," and I say, "I know, but it's the safest thing for you right now." Am I responding to the subtext of what they're saying to me? Julia, would you feel like I heard you?
I don't feel heard.
What do you think the subtext is when you say this feels like baby food?
I would think that you're treating me as a child. I don't have my dignity, my autonomy is taken away. I don't have any choice in the matter.
So if instead I responded to those feelings and I said, "You're right, anyone would feel really frustrated by this food. It doesn't look appetizing. It kind of feels like baby food. But my goal is to get you back to eating more normal food. Can I share with you some of the ways we might get there?" Would you feel more heard in that response?
Better.
Yeah.
So we can see how responding to these emotions successfully leads us right into this idea of partnership with our patients. Now, this is not a discrete step in the process. This is something we're cultivating throughout. So it should be interwoven throughout our conversation to really level the roles. So again, we might be the experts in swallowing. They're the experts in their own bodies in themselves. So this works, we can work together to come up with a care plan. We're giving them a sense of empowerment, autonomy in the situation. So this might sound like something like what you said just really helps me understand the situation better. I promise to work with you and not against you. So once the process gets to this point, we might be having some of that choice talk that Madison showed in that first choice talk options talk, choice talk. Sorry, a little bit distracting out there. This is the opportunity to make sure that we're all on the same page and that the plan that we have is aligned with their wishes. Thank you, Julie. It allows us to make sure we're all on the same page before we move forward.
They're graduating. It's a normal healthy response to want to celebrate.
Exactly. We can
I'm going to
respond with
validate
empathy
that. So keep in mind, just to kind of hone us back in, we're talking about the fact that if you're not on the same page, you don't have to always make a decision right in that moment. It's okay to give space and time to let it marinate. So in acute care, that might be like going and getting a warm blanket, taking a moment to see another patient and then coming back.
So when we first started this talk, we contrasted this provider-centered approach, which emphasizes the provider's point of view or our recommendations as opposed to this patient-centered approach, which is ultimately what we want. But sometimes when this concept comes up, there's a bit of a misconception that we swing all the way to the point of options without really emphasizing our role as experts in dysphagia and providing a clinical recommendation. We're still considering their wishes and their goals and making sure that the plan is aligned with that, but we don't want to swing so far that we are just laying out options as all equal to them, because we know as clinicians that they're not all created equal.
So this is, in other words, the choices that we explore with our patients, it's not just a buffet of choices where selection's purely based on what seems appetizing to them in the moment. It's not like just the same shirt in a bunch of different colors, which one's your favorite. Some of the choices actually have consequences that we have to inform our patients about. And so if we treat it like it's all the same, then we're not really doing our responsibility as experts in dysphagia or as providers to help navigate that decision-making process. So looking at this from a patient perspective, if you are NPO and you're really thirsty and you really want that feeding tube out of your nose, and I do a video swallow test that says you're not actually ready yet to initiate an oral diet safely, everything we tried is getting into your lungs. If I said, okay, so I reviewed your study and we can, all of the trials were going down the wrong pipe, so to speak. We can take the tube out and you can start eating, or we can keep the tube in and do some exercises. Those are not, obviously, if I'm the patient, I know what I'm choosing. I want the hamburger. But again, it's not wrong for them to choose to eat, but the way that I explain those options, I'm going to want to bring in patient-specific factors and what I know about dysphagia management to help them understand their particular risk profile. So this might be something even I really like pulling in the Palmer and Padilla bolus framework to think about what's the likelihood that this aspiration is going to actually give you a negative consequence, and do I really need to emphasize that for someone like you, or can we treat this more like someone who might be someone who aspirates and is functionally aspirating but otherwise maintaining their wellness. So as experts, we want to work on assessing options and presenting them accurately without precluding patients' input, because neutrality isn't necessarily accurate.
So where does this leave us? We're hoping that we're feeling excited about using some of these tools and some of these conversation starters in our practice. Some of the things that helped us move away from feeling a little clumsy in these areas to having more confidence and having these conversations. It's great to talk these over with a colleague. This is how our presentation was born here, and we're still in this iterative process of refining these skills. We talk about cases all the time. We compared people's different risk profiles, their tolerance for uncertainty, all of these things that come into how they decide their wishes along with our support. Connecting with palliative care teams, if you have access to these wonderful experts in this area, they're just fabulous for learning how to have these difficult conversations.
It can also be helpful after you have gone through an episode of care with a patient to do some reflection with yourself and say, how do I feel like that went? Or reflect with your patient. We just had a really tough conversation. Do you feel like I heard you? Is there anything that you want to tell me that I didn't ask you about? Taking a moment to let your patients give you feedback about how well you navigated that conversation can also help you improve your skills and improve your comfort with them.
And with that, we want to leave you with this quote from a really wonderful book, Being Mortal by Atul Gawande. You may not control life circumstances, but getting to be the author of your life means getting to control what you do with them. So we see this as an invitation to help our patients continue to write their own stories. Thanks, you guys.